Good evening, everyone, and welcome to tonight's sponsored webinar event, The Benefits of an IP Thoracic Surgeon-Led Lung Nodule Program, powered by the Galaxy System. We want to thank Noah Medical for sponsoring tonight's webinar and their continued support for the SAB over the years. Before we get started, a few simple reminders. Everyone is currently in a listen-only mode. People may ask your questions throughout the lecture. We will address all of them at the end of the presentation. You simply submit the question by using your question feature. It's located on your control panel and a little drop-down arrow. At this time, I'll hand it off to Dr. Kovacs, who will get us started, and thank you all for joining.
Oh, thank you, everybody. I appreciate being able to talk today about really the No Galaxy system, but also its part in our building of our lung nodule clinic and our lung nodule program, and how it's become a really integral part of that process. So next slide. So I'm going to start off with kind of the basics and kind of the big overview of how our program works, and then building into some of the benefits that Dr. Bhadra is going to talk about, dealing with some of the cost effectiveness of it and where we can build on that, and then Dr. Tsai's approach from the surgical perspective. But to start, what I want to kind of go through is a background of really what we believe makes a good lung nodule clinic. It really has to come down to dealing with the vast amount of lung nodules that are there, dealing with lung nodule kind of best practices and how we clinically evaluate people, the teams that we use, the main players involved. And as part of that clinical evaluation, utilizing, going through some of the different risk calculators and biomarkers and the protocols involved, and all of that kind of leading to those patients that are of a higher risk, that do require an early diagnosis, and then advancement through to our surgical and oncology teams. And that really advanced diagnosis at this point really comes with the NOAA Galaxy system, and it's opened doors for us we really hadn't been able to open until now. Next slide. So to kind of get a process around this, I know most people here in this talk know this, but to me, every time I hear it, it's always staggering that, you know, you have over 1.57 million nodules found in the United States every single year, typically through incidental findings. If you were to break that down, that's about 1 of every 500 chest x-rays have a lung nodule on them, and 1 of every 100 CT scans. But the problem with these nodules is the vast amount we find is that it's difficult dealing with them and getting them through where they need to be. When you look at multiple different insurance-based registries, on average, about 36% of those lung nodules that are found undergo workup, which means there's over 2/3 of them out there that are just out there, and they're difficult to be captured, and they have not been able to move through a program for multiple different reasons. So the goals are to really grab all those nodules, but really, as we have a volume of that high of a magnitude, be able to really start to work them through the system so they can be worked up, diagnosed, and managed appropriately. And of these populations, when they're found, typically it's with more regional or even distant disease, which, next slide, becomes more difficult. So a lot of the limitations that we deal with lung nodule management is that, one, as we all know, these typically don't cause symptoms, especially in the earlier stage, which means a lot of the incidental nodules that are found through emergency departments or family doctor's offices, if there's no symptoms and people feel better, just kind of go along their way. And unless they're tracked and monitored appropriately and move through a system, it can become very difficult. And if these nodules change and they're found much later on, typically they're more in an advanced stage by the time they cause symptoms. These are risk variable populations. We deal with nodules in non-smokers, smokers, and depending on their family history, as well as regions they live in with different occupational or recreational exposures, it does change how we look at these patients. And a lot of practices, a lot of places deal with kind of the single practice management, where a lung nodule program is not always multidisciplinary. It's either the one doc in town that does nodules. Sometimes these are stuck through oncology departments because there is no specialist that's able to work with them. So this lack of ownership leads to lack of communication and lack of resources to really move patients where they need to be and make sure they're getting the proper workup. And then limitations on technology. There's a lot of nodules now that still go through CT-guided needle biopsies because they don't have the equipment that they need to feel comfortable performing a successful peripheral bronchoscopy, or they don't have the ability of of having procedure expertise to do that, and they don't have the proper workflows in place to set these up, especially in more private practice areas or in areas where you keep the lights on by doing more consults versus bronchoscopies. So I think understanding all these limitations and building them through a funneled program where they're being met and dealt with and overcame is where you're going to lead into success. Next slide, please. Because as we deal with these, we start dealing with not just finding lung nodules, but again, these coming through, but whether incidental, whether it's through interrogating the EHR, dealing with the referral networks and screening programs. Next is that being able to look at that is being able to risk stratify them. So even when nodules are found and brought into the system, getting them down the right pathway is important, so that we're trying to do our best to figure out which ones can be moved into a more of a observation criterion than ones that need to undergo a more diagnostic procedure. And then again, with the intervention follow-up, being able to have appropriate bronchoscopic platforms that's going to allow you to get to a peripheral nodule with a high level of confidence, being able to stage those patients appropriately, making sure the patients are educated on how that's being done, any appropriate molecular testing, and then the handoff for thoracic surgery, being able to have that shared decision-making, both not only between physicians, but between physician and patients based on their location, their preferences, their levels of education. All of this needs to be understood, and I think work through an appropriate lung nodule program to ensure patients are not just captured, but maintain that same level of care and that same level of ability where they're comfortable and moving through efficiently to get to the way where they need to be. Next slide, please. Because as we know, the later we find these, the worse they get. So the problem with when you look at overall averages to diagnosis, specifically from when a nodule is found to when it's done, can be anywhere from 25 to 53 days on average. Now, some programs are much faster than that, but unfortunately, a lot of them are much slower. Data coming back through 2015 showed the average time for diagnosis was 3 to 6 months prior to. So we've made headway, but we're not near where we need to be. And unfortunately, as we know, the longer these programs that don't have kind of appropriate protocols and personnel, they will take longer to get worked up and longer to get diagnosed. And the more time that we spend in the workup process, the more time that we lose in the therapeutic process. Next slide, please. So the goal is really to identify these as early as possible. But how do we do that? Which goals do we look for, whether we're looking at surveillance or intervention? Because the majority of these nodules are benign, and we don't want to put somebody through a process or a procedure if they don't need it. If this is something that can be followed, we want to make sure that we're trying to put as many of those people in that bucket as we can to get them through and maintain that level of close surveillance follow-up, and not necessarily put them through a procedure where there would be even small but still inherent risk. And again, the flip side of that, we want to catch these early, because the high level of survival at 5 years is when these nodules, as we know, are smaller than the earlier stage and more in the peripheral findings where they can be amenable to surgical resection and a lot of these minimally invasive lung-saving surgical procedures. Next slide, please. So really the goal of this, we want to improve time and efficiency of lung nodule detection to lung nodule diagnosis. Next slide. So to do that, I think the best really goal is to have a multidisciplinary practice. And by multidisciplinary, it doesn't mean everyone's under the same roof, but I think it's looking at the goal of tonight's talk is to have, whether it's an IP thoracic surgeon-led practice or advanced bronchoscopist thoracic surgeon-led, or whether oncology's in, or whether you have a radiology component as part of that clinic. Some clinics are run by APPs, and all of those are valid. There's not one best way to do this. It's whatever works best based on your resources and based on your personnel. But I think there's certain goals that need to be hit no matter how you run your program. Really, when it comes down to is nodule recognition, and that's whether it's incidental or screening, but moving them through. A lot of these kind of start with manual tracking, which we learned is very, very problematic to try to do this high number manually. So looking at different software-based solutions to ensure that we're capturing as many of these nodules as we can become very important. And I think the most important step of this program is to have a point person, that lung nodule navigator, to facilitate referrals, to be that patient liaison, provide that level of education. And then the procedures we use to evaluate nodules, when we do capture them, we're doing a clinical evaluation, but we can apply different lung nodule calculators. We'll talk a little bit about where those can be beneficial and some of the drawbacks. Blood-based testing. We utilize Notify primarily here as an ability to help us try to figure out, an extra piece of information, which ones we can move to a lower risk category and which ones may be a higher risk to help us move forward, especially if they sit in the middle of those kind of moderate, intermediate risk patients. Sometimes you don't quite know which direction to go into. And then really, once we have them down that road, being able to diagnose them efficiently, being able to have a procedure where we're comfortable that we're going to get to our lung nodule with a high level of accuracy to minimize some of the inherent flaws with some bronchoscopic procedures. And for us, it really has been the ability to move to utilize no Galaxy system with that level of image integration into our workflows has really started to change the game. The types of nodules, the size of nodules, the position of nodules that we could go after, that whether they were high risk, we knew some of the limitations we had in the past that we're starting to overcome those with this technology and really what the doors that's opening us for us. And then after that level of diagnosis, having that high level of handoff communication, whether it's through thoracic surgery or oncology or the combination of the like, really helps move this process forward. Next slide, please. And again, it's kind of lend us where we deal with recognizing lung nodules. A lot of it we deal with so many different courses, whether it's coming from direct referrals, which is kind of the classic standard way. A lot of the early radiology components was utilizing manual spreadsheets. So it's, they put everything on a spreadsheet, but it's impossible for a human to really go through those hundreds and hundreds of nodules a day with all the other workflows they have. So now what you're seeing is software-based solutions, which I think is really changing the game on this, whether it's those based through a radiology program or systems like Eon, which we're looking to integrate, which gives us more of a natural language processing of reports that can open up opportunities for us really outside of just our radiology area, where we can manage large numbers of these with the limited resources. Next slide, please. And again, all of this comes into our navigator. And I think this is, I am much more replaceable than she is, because this really is the linchpin when it comes to a successful program, because they have to provide the piece from the outpatient setting to me to the communication. And that's really what they do. So they're the point of contact for all of our referring physicians. They will call and ask her how we put CAT scans in the way that we like to see them for bronchoscopy. They'll ask her questions regarding patients for lung cancer screening and how they go through the process on that. She has direct contact with the patients, helps move them through the process, finds which one of us has the next, moves our availabilities around so we can perform bronchoscopies at a high level of speed, efficiency, and accuracy. And then really helps facilitate that handoff from navigator to navigator. So as they move into our thoracic surgical area, if they're staged early and are appropriate surgical candidate, or whether they need to go on through oncology for those types of evaluations. Next slide, please. Because the problem we look at, and I think everyone in this talk kind of knows this area here, is these nodules vary. I mean, we've got a lot of risk factors on board, but all of them are very vague. Bigger spiculated nodules tend to be worse. Those that grow tend to be worse. But the problem is that many patients come in with either some, none, or all of these components, and we have to try to figure that out when it comes to a risk pattern for this. So putting all this together, just from a clinical standpoint, becomes really, really tricky as we're doing this. And you have some slam dunks and some easy ones, but the majority of them kind of sit in the middle. And that's where it becomes difficult sometimes to really kind of follow this through and look at the correct way to deal with these nodules when you could go down multiple different patterns just based on their radiographic pattern or their clinical presentation. Next slide, please. So next slide. So as we look at these calculators, we got a couple different models on board with that. I think the most common one we utilize to help us with this is the Mayo Clinic one. Now it's highly validated, widely acceptable, utilized throughout. The problem is that there's certain pieces that it doesn't take into account, like growth rate and PET results and things like that can sometimes make the calculator more difficult to utilize. Other ones are the Brock model, which we use a lot from kind of general population screening, but it does an overestimation in patients that are never smokers on the space and the size of their nodule, but they're risky cancer. You have the Herder model, which pulls in PET with it, but without PET, it's got a lot of variability in reporting and limited use. The VA model, the Gerner model, the Bayesian, the BIMC model, which has got some accuracy concerns and comparisons. And sometimes we try to fit our calculator for our patient, but the problem is every patient's different and they don't always fit within the calculator. So I think the calculators are helpful to kind of give you an idea of where to start, but it is by no means kind of the end all and be all when it comes to the level of risk this patient has and what direction they really should be going down. Next slide, please. because this is the problem with lung nodules, right? We always get these two that come in. I got a 70-year-old smoker where you calculate their Mayo risk of 34, and they've got this 10-millimeter peripheral right nodule, and they have a 49-year-old smoker with a malignancy risk of 11%. Next. But the problem is the one on the left here was benign nodule that after 2 years of follow-up didn't go anywhere. And this was nanocarcinoma that I diagnosed last week. So therein lies the problem with these. And having extra steps on board to help us try to figure out what direction to go in with this is really necessary in my mind to move this program forward. Next slide, please. So for us, I'm going to talk a little bit about blood-based biomarkers. And when we look at this, and this was data they presented through Notify back in 2021, but you're looking at these kind of pre-test calculators, and and a lot of them kind of sit in that moderate range, and the goal of it is kind of move the ones that don't need to be moderate out of that, and the ones that do need procedures to move them up to where they need to be. Next slide. And then, next please. There you go. And then we look at my data with this too. It's you know, as we look at this this was our kind of 120 patients looking through, and what we found was that patients were kind of in the middle utilizing these based on their clinical characteristics. We were able to move a lot down to the lower risk category and reduced risk, but we also found a lot that actually were the higher risk than we initially thought, we initially calculated, moving them to a level that we needed to do a biopsy on that we didn't, you know, we were kind of on the fence before, and that's what moved us into kind of where we needed to be for these kind of intermediate to high level risk nodules that to me require a diagnosis. Next slide. And for us, that requirement diagnosis, next slide, is a bronchoscopic evaluation. Now, the reason, one, is because obviously we do a lot of bronchoscopies, but we can get those done quickly. And I think the issue that we find a lot is getting bronchoscopies done quickly, getting the diagnosis quickly allows for time for workup of surgical treatment, allows them time to get their stress tests and all their pre-surgical workup done. On average, that looks as about a 41-day process, you know, versus going down roads like CT-guided biopsies or having to repeat procedures where those times are added. Because, you know, as we find a 5-year survival, whether it's, you know, if a procedure is done in less than 60 days, it's pretty high, over 85%. But when that time takes longer, that level decreases because we've given time for things to change from diagnosis to resection. So really our goal is to shrink that time of finding the nodule, to diagnosing it, and allowing as much time as we can to allow appropriate surgical workup and management around that so these can be treated appropriately. Next slide. The issue we had is that up until recently, with all the technologies we had, we were never ever as good at this as we wanted to be. Whether it was the advent of Super D, we started looking at the yields up front, where in the 60s, kind of early 70s, which was really good back then for that technology. And even with the advent of robotics, kind of got us into that kind of 70s, 80% range. But on average, when you look at this across the board, 74 to 77% on all the kind of published data, no matter what system it was, whether it was Monarch or Ion, you know, better than we had, but not where we wanted to be. Next slide. And when we kind of broke this down, I mean, even a lot of the early Monarch data, including the study we did back in 2019, really kind of come down to that kind of mid 60 to 70% range. It was a safe procedure. It got us where we need to be. We could find the nodule a lot of times under rebus, but you know, the level of diagnosis we had from that wasn't matching up with what we were, where we thought we were, and what we, you know, what we're seeing with rebus was not coming onto the slide and really looking at that to give people a true diagnosis. Next slide. And you saw a lot of similarities on the Ion side as well. A lot of the early papers that kind of came out, it was just Ion alone, you know, really no advanced imaging, but they were kind of getting kind of similar stuff, 70s, 80s, you know, we're all within a standard, you know, all within a mean of, and within a standard deviation of each other on how these systems work and how they're reported for that. Next slide. But what was interesting to me is that, you know, the goal, the benefit of robotics, can this fix this? And it should be able to. And I think it did. A lot of the first generation robotics were able to fix this up to a point, because what it allowed for is stable scope tip at the time of biopsy, lack of movement, you know, micro movements that were there. But the problem we had through multiple different papers and studies was CT to body divergence. And that has been a shortcoming, because where a nodule is not always, or where you think a nodule is not actually where it should be. And a lot of the older tech told you where it should be, not where it was. So integrating imaging, you know, the thought process that should that be able to help? Next slide. And what we kind of find with that, again, with a lot of the ION papers that came out, is when they were to build in cone beam CT or mobile 3D imaging, that level of yield really, increased. Whether you're looking at Mike Pritchett's data or whose, it really kind of changes the game of using the benefits of both of these tools here, of having advanced imaging as well as having the ability to have a stable platform that's reproducible, really showed a complementary benefit to the levels of where we wanted to be. The problem that a lot of us have, myself included, is I don't have a cone beam in my ROG suite. I've got one in the hospital, and I can get it on a Saturday if I want it, between the hours of 4 a.m. and 6 a.m. There's limited opportunity to utilize these type of things. So looking for other technology to give you similar levels of diagnostic yield, but with the resources and the tools that you have to be able to do this in a high volume within your workflows is really, to me, where the NOAA Galaxy fits in. Next slide. So really kind of where this plays on board, one is that you've got a couple different pieces here. One is you have integrated tomosynthesis. So this is using multiple images from a 2D C-arm, and I've got a old 1989 GE C-arm sitting in my room, and being able to have those multiple 2D images and reconstructing them to 3D images gives me these tool and lesion ability. I have augmented fluoroscopy throughout the entire case, seen in multiple angles, confirming my tool and lesion to help me overcome the CT divide divergence. These scopes are disposable, so my workflow becomes just as fast, if not faster, because my team's not worrying about cleanup time. They can get rid of the scope and it's gone. I still have the same, it's a 4 millimeter outer diameter scope, which was the level that I was using with Monarch, but just the camera alone, and I still have a 2.1 millimeter working channel. We have EM navigation still, but the ability to kind of augment that with the level of fluoroscopy really helps bring the whole thing together. And again, small footprint, fits in my room, fits with my C-arm. I'm not bouncing off different things. And it's really been a nice workflow addition to what we've been doing with the high level of robotic cases that we do. Next slide, please. So to kind of look through these cases, let me show you kind of this first one here. That we're looking at. So this is a gentleman came to see me, he's a 75-year-old gentleman that had a history of prostate cancer from about 10 years ago, and now comes back and sees us because they were doing a routine CT surveillance and saw this nodule in the right upper lobe that showed some PET activity. So to kind of take you through this is the picture of the Galaxy system. This is the same screen that I see with this, and what my ability allows me to do is have that camera on, but do a 15-second spin just of my C-arm from a 30 degree to 30 degree and give me these tomosynthesis images that I can now spin in real time compared to my CAT scan and really find where my nodule is located. And then once I find it, I can zoom it in to make sure we're seeing that in multiple planes. And now once that's in, I've recorrected with this with this system to where my nodule actually is. So I have now overcome my CT divide divergence, able to get on the target that's there. And once I'm there, I can put my needle directly in and around this nodule, right through the augmented fluoro, and repeat that tilt spin, which takes about 15 seconds to do and a minute to get the data back. And I can see my tool and lesion. You can see here, I was actually a little below this lesion. I was kind of catching the bottom edge of it when we were looking at this based on kind of where it was eccentric to the airway. So again, with that information, kind of making that hole in the airway, I was able to redirect my needle and then my forceps to where I needed to be to maintain inside that level of augmentation. And here's my forcep kind of going straight down right through the hole into the middle of the nodule. And this came back as a metastatic prostate cancer, even though he was diagnosed 10 years ago. Now he's got a recurrence of that. Case that I would have had a lot of difficulty getting to before without having that ability to visualize exactly where I was going eccentric to the airway. Because as you know, a lot of these nodules are not in the airway. Next slide, I'm gonna do one more case. And this to me was a case I just did last week that really showed me kind of the benefits of overcoming CT divide divergence. So again, this was a gentleman underwent a lung cancer screening CT. You can see he's got an AICD in place right above where this nodule is located. All right, this is a 18 millimeter lung nodule, spiculated, higher risk inside the upper lobe there, kind of apical, classically a little different area. So I've navigated to that, and this also integrates with radial EBUS. So this was one that I ran the radial EBUS, didn't really see anything. So I do tomo, And what I thought was a nodule turned out to actually be a shadow of the battery from the AICD. You can see as we spin around this. But I'm not seeing a clear nodule with this, where the EMN nav kind of told me I needed to be. So having now the ability to repeat a tomo spin, and we just did it a little slower to get more information. And by slower, we did 18 seconds versus 15 seconds. But that ability to give the system more data and it can adapt to that data allowed us to be able to recreate that airway and lung again in a way that gave us more information and more clarity. So again, as I start spinning this around, I see the same little battery I saw before, but now all of a sudden, when I start looking behind and slowing it down, I see a nodule. And I see an area right above there where you start to see as I zoom in, I'm a good 4 centimeters away from that. But now that's looking a lot better than what we did before. And again, looking at that at multiple angles, moving that through. Now that I've corrected for my CT to body divergence, I can rotate my camera over to where it should be, kind of lining that up to where, not where, again, because I think this gentleman's AICD threw off the nav, but I could run my rebus through, and now all of a sudden, an area where I thought was a nodule under tomo, I can now see this under here. So that little bugger couldn't hide from me at all. So now that's where I was with, and then that's where the nodule actually was. And I think this is the benefit of a system like this, because a lot of the first generation systems, no matter what technology you use, does not overcome for CT to body divergence. And being able to kind of run the tools through and have the ability to take both these together, I'm using kind of radial and tomo, and this is my needle out. You can see I'm directly in the center of this nodule that was there. So the ability to kind of lock onto that position and keep it there allowed me to take multiple needle passes and forceps. And then we used selectivity, which saw this was consistent with the squamous cell cancer. And this is one with whatever technology I had before advanced imaging, I would have missed. Right? I would have been where I thought it was. I would have made myself believe what I was seeing on a rebus may have been the nodule, and I would have gotten, benign bronchoepithelial cells, the 4 dirty words of the Bronx Suite. And now I don't have that level of worry anymore, because now I can see exactly where I'm going. I can see those nodules, especially in the periphery where they're harder to get to. And it's really become a huge benefit of building this into the workflow of an efficient program. Next slide. So to conclude my part, I think that as we know, the time where this becomes helpful is that I'm rapidly diagnosing peripheral nodules that are smaller, that tend to be in an earlier stage. So far in the early use we've used with this technology, we're staging them at the time, and then right at the time of pathology comes, I have a conversation with my thoracic surgeon. And oncology. I have the benefit of being under the same roof as both of them, but we can have these conversations in real time to allow that patient to come in. As they come in, we're reviewing data with them. We've discussed their diagnosis. We have navigator handoffs, and allow for this comprehensive communication. And I think, as we've evolved programs, as we have evolved our ability to have software-based solutions to find nodules and have blood-based markers to help us evaluate them, we finally now have a really ready-to-use system that integrates simple things like fluoroscopy, but allows that simple integration to move us into a peripheral-based system where we had limited access and availability before without large, expensive, advanced imaging. And if you have that, great, that's fantastic. But those of us that don't, this allows us to do that. Use the old Apple phrase, it was a computer for the rest of us. In my mind, Noah Galaxy is bronchoscopy for the rest of us. It allows us to really move that forward with the tools, the resources we have. So now we can allow that evolution of technology to match the evolution we have of the nodule management practice, and allow it to continue to move patients quicker, stronger, more efficiently to the levels they need to go. So, that's kind of my overview of this. And I'm really excited to introduce Krish Bhadra to kind of talk about a lot of the benefits above and beyond to show these programs where they seem more difficult to run, but in reality, I think we find that the ability to really maintain these and make these systems that are very vibrant and sustainable become important. So, Krish, thank you so much, and I'll turn it over to you, buddy.
Thanks, Stephen. We're going to be talking about intra-procedural development and capturing downstream, and talking a little bit about the nitty-gritty about how to do bronchoscopic billing and how to show your worth to the administration. Next slide. So the first slide I'm going to talk about is, we're going to get right into it, which is basically how do you code, how do you understand coding, and understanding how to utilize these codes in combination so that you can demonstrate your value. Now, when you're looking at complexity coding, which is a concept that actually was first introduced to bronchoscopy in 2016, there was a recognition that if you build for EBUS and EBUS alone, and then when you perform the navigation, that it would get lost with the multiple endoscopy rule. So as a result, Medicare made complexity adjustments. And what does complexity adjustments mean? That means when you perform a navigation bronchoscopy in conjunction with an EBUS, your reimbursement is increased. And that's only fair because you're doing a very technical procedure with navigation in combination with EBUS. They don't want to see us divide those procedures into two different time points. It's in the interest of the patient to undergo both at the same time. When you look at this slide, it's a little bit busy, but I'll walk you through this. So essentially, you can see here this gray shaded area, the reimbursement for the CPT codes, which are going horizontally when there's 31622 is a complexity adjustment of 5153, and your reimbursement is around $3,334. However, if you were to perform EBUS bronchoscopy in combination with the complexity code of 5154 or 5155, your reimbursement improves to $6,187. Now, these are not numbers that are comparable to neurosurgery, thoracic surgery, cardiovascular. But one of the major aspects of program development is that you want to make sure, number one, that you're not losing money for the institution, that you're able to demonstrate a profit. Otherwise, your program's not viable. And then the other aspect is that you as the provider have a responsibility to be able to ensure that the institution is actually getting their reimbursement that they deserve so they can continue to support your program. Next slide. So understanding complexity coding, let me give you an example of what I would do for a robotic assisted bronchoscopy case coding. And so if you look right here, I'm going to just walk you through some of this. It's a busy slide, but let's just go through it. You got 31641, which is the cryoprobe code. So if you're performing cryoprobe biopsies, you can utilize that code. 6153, the next code is the EBUS code, and the 29, which is the needle, the forceps, the brush, the BAL, and then the add-on navigation code, which is the 27, and then you've got the peripheral probe EBUS. When you bundle all those together, you're looking at the maximum reimbursement. And then there's also additional codes if you're utilizing cone beam CT bronchoscopy, which I utilize a lot, where you can apply VRT vendoring with the 76377. And then I always get this question is, how do you bill for cone beam? It's 77012 is for CT guidance. Next slide. So it's very important as you look at this slide to use that as an example and compare that to the way you bill, and then make sure that you're utilizing all the correct codes. Now, when we talk about intra-procedural billing, that's only one aspect, but navigational bronchoscopy and the diagnosis of peripheral lung nodules is a downstream revenue model. And so you've got upstream development, which is identification of lung nodules, intra-procedural development, which is performing the procedure with a positive contribution margin, and then you have downstream revenue. So if you walk through the patient pathway, patients undergo CT scans. That's an upstream development. They have an incidental lung nodule that's identified or a CT screen that's identified. All that upstream then leads to imaging and a diagnostic procedure. Typically in our institution, it's a diagnostic bronch. And then they undergo treatment. And treatment obviously is your downstream players, which are going to be radiation and medical oncology, thoracic surgery, and all of the other adjunct services like palliative care, hospice, etc., that might be involved. And of course, there's also imaging involved. And so the downstream revenue can be as upwards up to $49,000 per person. And if you think about that, that's an astonishing number when you start to put together when you have volumes of 100, 200, 300 navigations per year, and it starts to make a lot more sense. Next slide. So this is an example of our hospital in Chattanooga, Tennessee, a CHI Memorial. When I came here, we had a total treatment volume of 394 patients that underwent a combination of chemoradiation and surgery. And if you look at that top number, when we fast forward to in 2020, you can see that we almost doubled during that time period. So as we utilize navigation bronchoscopy, as we adopted it, we noticed that there was increasing numbers of lung biopsies, and as a result, increasing identification of lung cancer. Next slide. So this is an example of what we saw, at least in the early stages, for contribution margin. This is back in 2013. If you take yourself down to here where it says interventional pulmonology, you can see that year over year we had a significant increase in the total contribution margin. The total pulmonology group, which includes multiple other bronchoscopists at that time that were doing advanced bronchoscopy, for a significant, almost doubling of their contribution margin. And next slide. And when you look at it as a whole, you'll see that you'll have a significant increase in the total contribution margin of your program. So essentially, as you diagnose more lung cancer, your contribution margin for yourself and all of the downstream players, thoracic surgery, medical oncology, radiation oncology, increase. Next slide. And so when we talk about healthcare costs, so when we look at stage 1 lung cancer, we obviously know that that has a better outcome, a 5-year survival rate of 92%. And then with stage 4, a 5-year survival of a dismal 10%. And when you look at healthcare costs, essentially you can see that as the longer you wait, the more cost it is to the system. And that's another aspect that needs to be understood. It's not just demonstrating revenue, but you're cutting costs for patient care. Next slide. So here, if you look at our total program, since 2012, if I were to take you here to stage 1 disease, we started with 91 in 2012, and that increased to 2017 to 179. And so this is actually the story that's really important, is that we had a significant increase in stage 1 and 2 disease, and we had a significant decrease in stage 4 disease, and the total number of cases also grew during that time period. Next slide. So as you approach that advantage, we talked a little bit about the billing aspect. You want to make sure that you're billing correctly. You understand APC adjustment codes for complexity billing. You'll notice that you'll have a positive contribution margin, but not only that, all boats will rise along with it. So as you build out your navigation program and lung cancer program, everyone gets to participate. Then let's talk a little bit about cost. And cost is a significant aspect of navigation bronchoscopy. And when we're talking about what are you going to do? So I have access to cone beam, but I don't have access to cone beam every day. And so that is actually a significant problem for myself and for other people who are out there in the community, don't even have access to cone beam CT systems at all, whether it's COS or fixed system. And so if you look at, from a clinical standpoint, if you have a Galaxy system, you can use your standard C-arm that's in your hospital. And so I use a GE 9900, and we actually have at least 4 of them within earshot of the bronchoscopy suite. And then for the first generation robots, you don't have anything. You can use Radial Pro EVIS, and then you have to replace it from time to time because they do get damaged because they are disposable products. Or you go out and you spend an additional $500,000 for mobile cone beam, or you spend an additional $1.5 million for a fixed cone beam. And if you actually look at fixed cone beam costs, you actually have to build a room if you don't have access to that. And so that cost can then drive up into the millions. And so when you're thinking about building a program, starting a program, and expanding it, like myself, you're going to look at cost and going back to your C-suite over and over again, asking for items, and making an ask for a singular robot that can perform in a cone beam room and perform outside of a cone beam room is really a very good value added prospect, and which is why I have been very interested in moving forward with the Galaxy platform. From an operational standpoint, this is also really, when I got my, I am an Ion user, and also I'll speak from my experience. We had to buy scope washers. And so one of the things was that this was a hidden cost. I actually had no idea that when we bought our Ion that we actually had to have an infrastructure to clean scopes. And this became a major issue because for me in my hospital, like many other hospitals in the time of COVID, when hospitals are not doing well, asking for additional capital is difficult. Asking for additional labor is even more difficult, at least in my hospital. And so essentially it becomes a very problematic issue. So we had to spend around $60,000 for 2 Steris Endo 1 machines, or if you have a Medivator, you'll be spending money for scope washers, basically these machines that will help you clean the scopes. You have to buy about $100 worth of scope cleaning materials per case, which is kind of a hidden cost that's offset onto the institution, and sterile water. And you have to have a full-time employee. So I do 500 navigation bronchoscopies, which is a very high number, obviously, but we had to hire somebody to actually clean the scopes. And if you think about that, this scope washer is so valuable to us that, you know, if they're gone or on vacation, it affects the flow of the room on every day. And we have a hard time finding people who want to wash scopes. And so, and no one inside of the bronchoscopy team wants to go and wash scopes. That's not what they signed up for. And so if you think about it, if I'm a bronchoscopist and I'm spending time talking about cleaning materials for your first generation robot, there's already a problem inherent in that. The good thing with Galaxy, it's a single-use disposable bronchoscope. You just take it off and you throw it away and you start over again. Next slide. So we talked a little bit about water. So one of the things that was really startling to me was you had to have critical water. Critical water is defined as many different types of water, including sterile water, which is expensive, deionized water, etc. So you have to have 18.9 liters of critical water to wash one scope. And you can imagine we have a lot of water that we have to store, and we have to lug this around, and we have to make sure that we have it readily available. And water goes on national back order. I did not know that. And so we've had times where we've had to go out and seek more expensive options for water. So, and then there's the environment. And of course, that plays a significant role as we go forward when we're thinking about these types of decisions. Next slide. So we had one of the things that's really important, and I touched on this, is that we needed to have one person wash a scope for 1 hour. And we were told that we were not really able to rely on sterile processing department, or SPD as it's often called, because the scopes were just entirely too delicate. And I understand that, but it's a 20-step process. Next slide. Let me show you how difficult it is to wash a scope. So here's the 20 steps that a person has to go through. And then you say, okay, and then they'll tell you, they, as in the people who manufacture the robot, will say, hey, if you get one of those scope washers, you don't have to take as long. Well, that's not entirely true. It doesn't really cut off that much time, because you have to get down to step 17 to be able to actually utilize the scope washer, and it doesn't save all that much time. So you're still kind of stuck there, and the scope washer has to watch over the machine and make sure that it's ready for use. Next slide. So we talked about these cost issues, but there are some real pain points when you think about this. You have to have so they send the scopes and they're not even clean. So you have to actually get a scope out of a box and then wash it and then use it. And so it's an expensive process. It's cumbersome to clean. It's an entirely hidden cost. They don't want to talk about it. I get it, because it's a pain. And then you have to have a high par, because the scopes are often break during the repair process or cleaning process. And there's no independent scope process. And this is my favorite part, is that if you damage a scope, you have to send it to the company and they say, oh, it's your fault. And so there's no way to really you're gentle with the scope and you're trying to do everything right, and the scope is essentially billed to you. And then there's another concept called catheter drift, and I think other users and Kovacs can maybe speak to this a little bit, is that I noticed that the catheter doesn't necessarily stay stable. And I don't know why, but I would assume that it has something to do with catheter stretch, along with catheter or issues with the catheter maintaining stability. So it doesn't perform as well after you've cleaned it multiple times. And so I have experienced this phenomenon that I termed as catheter drift, where the catheter just isn't as stable. So the benefit of the Galaxy system is every time you open up a kit, it is brand new, like as if you were getting your brand new iPhone. So that's nice. Next slide. So the benefits of single-use bronchoscopes is, don't gloss over this slide. It's workflow efficiencies, it's easier to set up, repairs and maintenance costs are significantly reduced, zero scope fatigue and drift, infection control, God forbid that would happen, and then reprocessing costs and scopes and capital, and then reusable scopes reprocessing generates about 4 times as much waste compared to single-use scopes. And so keep that in mind. Next slide. So what is the image integration of the robotic assisted bronchoscopy, the iRobot? So with Galaxy, it's less expensive compared to other traditional first generation robotic platforms, period. Okay, so you have a value added prospect there. Your case biopsy volume will grow. It's going to grow for me because now I'm going to be able to do cases outside of my combing room. For those of you who have, when you have imaging guidance, it is the greatest equalizer for robotic bronchoscopists because essentially it allows us to be able to get to the lesion because we know where it is. Procedural efficiency, we will be able to add on costs. You have zero reprocessing and maintenance costs, both in terms of the capital expenditures and the FTEs. You'll have an increase in stage 1 diagnosis as you are biopsying more patients and catching cancer earlier. And then when you compare that transition from transthoracic needle aspiration to robotic bronchoscopy, which allows you to be able to biopsy multiple lesions, perform mediastinal staging with lower morbidity, mortality, length of stay, etc., you get a better contribution margin for the institution. And so that's extraordinarily important. Of course, patients are first in this process, but the hospital will be able to support you going forward because you are profitable. Next slide. So thanks so much. I'd like to introduce Dr. Wilson Tsai, who's a thoracic surgeon, and I look forward, he's going to talk about building a thoracic program from the perspective of a thoracic surgeon. So thank you so much, and I'll hand it off to you.
Thank you so much, Dr. Bhadra. I think kudos on you for making a extremely detailed and logical explanation about the economics of medicine. And unfortunately, I think what's going on, many of us practice without the understanding that some of these procedures may come at a significant cost. And in an age of decreasing margins and increasing costs and so on and so forth, having an awareness to, essentially what I call the microcosm or the galaxy of finances, of what you really do is going to be extremely important when we sit down and negotiate or discuss with administrators about what is important to our patients from how we practice. So that was a phenomenal talk, and I learned a lot about that as well, a lot with your talk as well. So great job, thank you so much. So I'm here as a thoracic surgeon to discuss how I use robotic navigation bronchoscopy in my program. And again, I use it a little differently from the way Dr. Kovacs and Dr. Bhadra does. Initially, I did everything they did. I was the one doing all the robotic nav bronch procedures. I was the one, seeing these pulmonary nodules. As a director of the thoracic program in my hospital, essentially, we were able to shift a percentage of those patients from the CT scanner into our OR, and that really built a program where we started becoming very sophisticated integrated and efficient in terms of how we really treated these patients in our community. Next slide. So as I said, you know, the way we started off was essentially having a thoracic tumor board. And again, you know, if you're coming from an academic center, this is going to happen, of course, almost, you know, naturally. But if you're starting off and you're going to a hospital that doesn't really have a true thoracic program, this is extremely important because of the fact that this allows treatment of these patients in a multidisciplinary fashion. The multidisciplinary approach to these complex lung cancer patients, we have known time and time after again has been proven to really truly improve 5-year survival rate for these patients being treated. And I think recognition and acceptance of the fact that it's not just one discipline that owns these patients, we really have to be all in and organized in order to make sure we're making a difference to save these patients' lives. So we present, you know, 2 times a month. We do about 5 to 7 cases per tumor board. You know, last year we had 20 boards and about 156 cases are presented. And most of these are all physician referred. You know, some came from oncologists, they came from thoracic surgeons, pulmonologists, et cetera, et cetera. And then subsequently what we did, we started incorporating those patients that were discovered in our pulmonary nodule program and our lung cancer screening program into the thoracic tumor board. So we were able to integrate some of these CT scans that need to be reviewed in a multidisciplinary fashion, which then subsequently facilitated you know, the efficiency of these patients getting either the proper surveillance, the proper diagnosis, and of course the proper treatment. And that's how we really started with this, was just to sit around in a group of about, you know, 20 of us and just talk about these cases. Next slide. So we all have this in our program, our pulmonary nodule program. You know, this is probably the most effective way to really make an impact on lung cancer. You know, of course, we have the lung cancer screening program, but, you know, unfortunately, in the current day today, you know, despite having a huge number of patients who are eligible for lung cancer screening, only a very small percentage, in the single digits, for example, actually follow through with obtaining lung cancer screening. So, you know, unfortunately, we haven't made a extremely important and effective way in getting these patients with lung cancer for their lung cancer screenings. And so we know that a majority of patients who are discovered with lung nodules are discovered incidentally. About 85% of these patients are discovered incidentally. And I really think that in order for hospitals to initially save costs, the focus shouldn't be on a Medicare funded or Medicare supported lung cancer screening program. Quite honestly, the data collection, the sort of record keeping is extremely onerous, at which time that hospital would most likely have to hire a full-time nurse navigator just to manage their lung cancer screening program. And so we initially started with the pulmonary nodule program. And of course, we all know these are these cases, you know, the patient goes to the emergency room, there's a small nodule that we see on the lower cusp of the chest when, of course, they're getting a CT scan for right upper quadrant abdominal pain, for example. And then what we really wanted to do is we want to make sure the radiologists were involved, and the radiologists subsequently dictated in their in their reports, this patient is eligible for the pulmonary nodule program, and then based upon their Fleischner guidelines, we would recommend either surveillance or, you know, biopsy and so on and so forth. And this is how we started, and this is pre robotic navigation bronchoscopy system. This is what we really want to do, to make sure that all those patients in our hospital systems, about 8,000 exams, were not being lost to follow up, and we were extremely diligent in making sure that these patients were treated accordingly. What we then did was we went to our Epic system and then had you know, sort of these dot phrases where we can help the primary care physicians order the proper CT scans for surveillance. Letters would go in as a templated form saying, you know, for example, your patient has been identified with a suspicious pulmonary nodule. Based upon our tumor board meeting and the multidisciplinary approach, we recommend, you know, the following X, Y, or Z. And we found that this was a great way to keep the patients within our hospital system, and more importantly, not miss cancers subsequently as well. Next slide, please. And then we finally, had enough patients in the pulmonary nodule program, at which time we said, okay, we do have to elevate our program. We had the funding, we had the, the proper finances to actually initiate the lung cancer screening program. And so we opened this, close to about 10 years ago. And these are all based upon CMS criteria. And this is, I don't know if anyone has tried to do this or anything, but this is an extremely data onerous sort of entry. A lot of work goes into this in order for this hospital to be paid for lung cancer screening, to obtain their low-dose CT scan. We've had about 2,000 patients scanned, about 3,400 referrals. Again, we had that full-time employee, the nurse navigator, who reviews and approves all the orders prior to scheduling, to our medical imaging department. The nurse navigator would then communicate directly with the ordering physicians when it's needed. Again, thought phrases need to be, constructed so that way it would make it easier and more efficient for these patients to get their lung cancer screenings. And then even surprisingly, despite all that, a majority of our patients still were not showing up to the lung cancer screening, despite the fact that we told the primary care physicians, that this needs to be done. The patients knew that they need to be done, but again, we found out that there was a very significant percentage of our patients who were eligible for lung cancer screening that never followed up for it. And so, internally, we were able to navigate, that problem. Essentially, all, that would help was, hiring someone, at a low cost to just call patients, 2-3 times a week, 3 days a week, just saying, hey, this is John Muir calling. You've been identified for lung cancer screening. Can we help you make your appointment today? And that's how, we were able to, increase the number of patients who would actually accept their lung cancer screenings rather than wait for, themselves to try to schedule and call in and stuff. Next slide. And so, what this does, this really increased our, lung cancer volume. But, at that time, we still did not have a robotic navigation system. There were 4 thoracic surgeons, and we did a lot of thoracoscopic cases, a lot of robotic cases. But of course, the biggest dilemma that we all had was essentially what do we do with those suspicious sub-centimeter nodules, which increased from 3 millimeters to 6 millimeters in a patient with a 50-pack-year smoking history, that's spiculated and now is solid. That posed a significant dilemma to everyone. The interventional radiologists would look around the room and shrug their shoulders and say, well, this thing's 6 millimeters. The chances of us getting a positive diagnosis of something so small is extremely low. So I'm not going to risk the 20% chance of pneumothorax to get something this small. The radiologist then subsequently look around the room and say, well, I don't think a CT PET scan is going to really be helpful, because of the fact that we know the PET scan component of this test is probably not going to pick up anything 7 millimeters, 8 millimeters, or smaller. And so we have this nodule here, which we all know is suspicious, but we did not have a way to really get to it. When we first got our navigation bronchoscopy system about 4 years ago, I wanted to make sure that as a thoracic surgeon, I did not replicate the same exact thing that interventional radiologists did, because essentially I knew that, because we didn't have cone beam CT scan, I recognized the problem of CT to body divergence. I knew that if I spent 2 hours, 3 hours trying to get at this 6 millimeter to 8 millimeter nodule, I'd be tearing out my hair. Let's be very honest, thoracic surgeons do not have the patience of pulmonologists to go and biopsy these nodules. And of course, in a very busy day, I have about 4 surgical cases pending. And for me to spend 2 to 3 hours trying to diagnose lung cancer in this 6 millimeter suspicious nodule, of course, it was not the most efficient thing to do. And so subsequently, I said to myself, the best way we could probably save these patients or help these patients is essentially to do, what I started off doing as the single anesthetic events. And so for me, I would go in and I would navigate my bronchoscope to the lesion, and I would inject ICG and Omnipeg and methylene blue directly into the tumor, into this nodule. Subsequently go in via a robotic thoracoscopic approach, and I would be able to identify this little green ball that correlated to the position of this nodule. prior to being able to dilocalize these nodules, if we went in thoracoscopy, there's no way we would have been able to even find these tiny nodules because they're not palpable. Many of them are deep to the pleura. So there's no puckering, there's no, sort of subtle changes in the contours of the lung. And more importantly, without doing a thoracotomy, you can't palpate these nodules. And even by doing a thoracotomy, and some of these nodules are so small and nondescript that you really can't feel it. So again, by employing the robotic navigation bronchoscopy program into the operating room, we are able to go after these sub-centimeter suspicious nodules based upon the risk calculation scores that Dr. Kovacs described. And we said, yes, this patient deserves a chance at making sure we cure them from cancer. And as long as we met a certain percentage of patients that we knew were truly positive for cancer, then our program would be successful in that way. So far, in our healthcare system, I have a paper pending on that, but we have about 92 patients that went through single anesthetic events, and so far we have a 100% diagnostic accuracy, not a diagnostic yield rate. We have a 100% diagnostic accuracy rate in localizing these subcentimeter nodules and proving that that patient has cancer or does not have cancer on that day of the wedge resection. And of course, this subsequently allowed us to really, condense our timeline. You remember the timeline that Dr. Bhadra showed before in his previous presentation, where they went for a diagnostic biopsy and of course a bronchoscopy, and the next wave in that algorithm was a referral to either a medical oncologist, radiation oncologist, or thoracic surgeon. We are able to condense that timeline, so we skipped a step. And so what we would do is the diagnostic bronchoscopy and the diagnosis of lung cancer would happen at that surgical event. And if it was proven that this patient had lung cancer on the frozen specimen, we would proceed with our mediastinal lymph node dissection robotically. Level 7s, 9, 8, 2 and 4 were all taken, on the right side. And of course, on the left side, we have our different, mediastinal lymph nodes as well. But essentially, after confirming there was no N2 disease, and we then subsequently went and did our segmentectomy for these subcentimeter nodules. And again, very much like the programs that Dr. Kovacs and Dr. Bhadra described, we significantly increased the patients that we in our healthcare system for treatment for stage 1 lung cancer. That is a huge deal for these patients, because as we know, the one thing that improves survival rate is, of course, the stage, and the earlier stage we can find and treat these patients, the better chance we have at making sure that that dismal 50%, 60% 5-year survival rate for lung cancer actually can start heading in the right direction. The biggest problem was, when I started doing that, we just had too many cases. And so as being the one sole guy that really was doing the lion's share of these robotic navigation bronchoscopy procedures, I recognized that I needed help. And it didn't make sense for me to go and, look for these other thoracic surgeons and say, hey, can you do more bronchoscopies for me? It made sense to go to the pulmonologists, who many of them were dying to really change their practice. In the community setting, even if you are fellowship trained in interventional radiology, the most stable source of income is the call pay you receive from covering ICU call. And so, we had a lot of these pulmonologists, of course, covering ICU call overnight, up all night. And the risk to them was if they said, hey, listen, I want to take less critical care call and start a lung cancer screening program, the overhead from their offices, the overhead from not having enough patients, that was a significant risk to them. Some of our pulmonologists actually started families with little babies involved. And of course, what we did was say, hey, listen, maybe we can help get you out of some call nights. If I can increase your volume for helping me with these patients, we can really row the boat together and become much faster. And so we had four pulmonologists now that do a majority of the robotic navigation bronchoscopy systems. And so the way we're designed is for those patients where we have a high index of suspicion for lung cancer, and yet we understand that the probability of a positive diagnosis intraoperatively without cone beam was low, these patients would then be seen by either one of us. And then at that time, on the day of the procedure, they would be consented for robotic navigation bronchoscopy, biopsy, dye localization, and then they would be consented by me for a robotic thoracoscopy, wedge resection, possible mediastinal lymph node dissection, possible segmentectomy / lobectomy. And so what we did was really crunch that timeline from the average duration or the average length of diagnosis, staging, treatment, from what's usually conventionally in this country, anywhere from 46 days to 60 days, down to about 4 hours. And that's a huge impact on increasing the survivability of lung cancer in our community. Next slide, please. And so, this was essentially a paper that I had published. I'm a community surgeon, so I don't have all the high impact journals. But again, I want to describe my experience with, what I did with navigation bronchoscopy. And you could see, by number one, improving reach and stability, we were able to really achieve very high levels of diagnostic accuracies in these procedures. Subsequently, you can see on the picture on the right hand side with the ICG fluorescence, we're able to really pick up these nodules. And again, as long as you do your wedge resection where all the green dye is encompassed in your wedge resection, you are not going to miss. And also, I know I do the one thing that many people can't do as a pulmonologist, and that's overcome CT to body divergence. Next slide. And again, as I described, this is what happened to us when we adopted the robotic navigation bronchoscopy program the robotic navigation bronchoscopy technology into our program. 2 years prior, our hospital system did 60 lobectomies for stage 1, 9 lobectomies for stage 2. 2020, just 5 cases left, but again, very similar numbers. Within 1 year of adopting the robotic navigation bronchoscopy system in our program, our hospital, again, we are a 2-hospital community hospital only, we more than doubled the number of lung cancer patients treated oncologically, staged correctly for stage 1 lung cancer. That is the ability to achieve that 92% 5-year survival rate in these patients by making sure they're diagnosed, staged, and treated all correctly. Subsequently, you can also see for our stage 2 lung cancers, we increased a significant improvement, doubled the number of patients with stage 2 lung cancer as well, getting lobectomies. Of course, there are new papers talking about the role of neoadjuvant chemo IO for stage 2 lung cancer patients. And again, we have incorporated that program as well. Next slide. This is a very old slide, and quite honestly, we've only evolved and improved from this. And so this is just talking about the role for robotic surgery in our lung cancer patients. As you can see, the light blue color represents robotic surgery. The dark green or the dark blue coloring represents thoracoscopic, or what we call video-assisted thoracic surgery, and the dark gray color represents open thoracotomy. And this is 10 years ago, when I started doing robotic thoracoscopy, I was able to show that my patients actually left a full day earlier if we did it thoracoscopically. We actually collated our data just very recently, and we saw that 83% of our patients undergoing lobectomies or segmentectomies leave 2 days after their lobectomy. And again, a certain percentage of them, 40% of these patients actually left on post-op day 1. So we were able to truly make a significant impact on these patients' survival rate with, again, the best cost benefit sort of improvement to the hospital in terms of DRGs and what Medicare pays them for expected length of stay and complications. And this is where the hospital truly makes money, because again, they get a standardized pay for these procedures. But if you can actually decrease or improve the quality of that, the hospital ultimately makes more money on that and cost savings on the back end. Next slide. And so, the value to the Galaxy system, to the thoracic surgeon, it really has to do with, I think shifting that curve and shifting those patients on to stage 1 lung cancers, treating patients with stage 1 lung cancers. As we know, in the past, without having such a sophisticated system, we were only watching cancers grow. And the concern about seeing these 6-millimeter nodules is everyone in the room had a very significant suspicion that this was cancer. But again, unfortunately, before the advent of robotic navigation bronchoscopy, no one in the room could do anything about it. And ever since this technology developed and has taken off, if we we have the right team to really shift the curve on this and truly make an impact in our community here. And as we know, the Galaxy system, despite in addition to all the cost savings, obviating the need for purchasing a very expensive cone beam CT scan, the one thing that the Galaxy system does that no one else has done is really putting a targeting system on this fighter jet, right? If you think about it, the other two systems, they have developed great ways to navigate bronchoscopes to the lesion. But unfortunately, the one thing that you can't do with these systems is you can't target a moving lesion, or you can't target a lesion that is not there because of potential CT to body divergence. So with their tilt technology, their augmented fluoroscopy, their tomography, and AI generated 3D reconstruction, that really puts a true targeting system for live evaluation of this nodule sitting in front of you, so that way you can turn and articulate your system towards the nodule. And again, that is a huge game changer, as these pulmonologists are really getting diagnosis in 8 millimeter, 6 millimeter lesions now, and that's a huge jump for the quality of what used to be there in the market. Next slide. So again, it's an honor to be finishing this off, this talk off, to follow after two great national figureheads in the world of robotic navigation bronchoscopy. And again, I welcome any questions. Of course, I want to thank everyone for their time and their attention.
Awesome. Well, thank you so much, Dr. Tsai, Dr. Kovacs, and Dr. Bhadra. I know we are over time, but just a reminder to the audience that we are able probably to take some questions. And while we're waiting for questions to come into the chat, we did want to take the opportunity to launch our Time to Treat dinner program. These dinners are coming up in Q4. So we have one this week, December 11th, December 7th, and December 21st, with Dr. Kovacs proctoring one of those. So feel free to go ahead and register if you're in any of these cities by using the QR codes there. All right, I'll see if we have any questions. Great. None quite yet. I think I have one, but just for anyone who is on the call who is about to start a lung nodule program or is going to a facility with one, what would be your first recommendation to them, their first step?
I think for me, yeah, I can start with that off.
Yeah, go for it.
Oh, thanks. So for me, I think it's, you're coming into a brand new place. I think the first is kind of learn the players with everything. So for me, when we first started, way back when, the old Super E days, one of the first things I did was I learned, you introduce yourself to your thoracic surgery group, you introduce yourself to your oncologist, you go out and you meet your PCPs, your referrers, the ones that really send you business, and you talk to them about what their needs are, what you do, and how you can work that together. Because then I think once that conversation occurs and at a comfort level, you start getting those patients. And I think if you're coming into an already defined program, it's still good to make those introductions. But then I think at that point, it's kind of helpful to kind of learn the players in your program. So get to know your navigators very well, and your nurses, and the process and the procedures. Whether you're doing bronchs and endoscopy suite or an OR, kind of learning those pieces there, kind of fit how you fit into there. Because in those places, you're kind of joining an orchestra. So you got to know how you harmonize with the rest of the instruments that are going forward. So I think of that, to me, a lot of that communication up front becomes very helpful about how you can help them and what they're doing, but also what you can add to the table to be part of that process as well.
Yeah, and I totally agree with that. And I think one of the things that particularly pulmonologists, I think Dr. Tsai would probably be a little bit more confident because of his thoracic surgical training, is that pulmonologists really don't understand their worth in terms of advanced bronchoscopy. Is that they're actually a key gatekeeper physician that allows patients to flow through, that then increase revenue, because they essentially are identifying these patients very early on. And they do a lot of the legwork to get them to treatment. Understanding, number one, that you're a gatekeeper physician is extraordinarily important. Understanding that what your worth is also extremely important. And then when you know that, then you should go and meet with your CEO, especially if you're considering, let's say, if you wanted to purchase a Galaxy robot. And that can be a very daunting task, is to go up to the CEO that you've probably never met before and say, hey, I am interested in talking to you about purchasing that. So well, the first thing I would recommend is, when you're talking to your CEO, is don't apologize for being there. You're there for a purpose. Don't go in there and say, I'm so sorry for bothering you. Say that you have a problem. Your problem is the biopsy of very small lung nodules, typically 1 to 2 centimeters in size, and that there is a technology out there that will allow you to be able to visualize the lung lesion, use advanced imaging to be able to become more precise. You'll be able to identify more patients, biopsy them, and catch lung cancer earlier. And you've garnered the support of all the key role players that Dr. Kovacs was talking about, including your partners in thoracic surgery and medical and radiation oncology. And this is going to be good for the hospital, the patients, and you really need the support of the C-suite to be able to acquire this technology to move forward with this program. When you say that and you talk about your issues and trying to communicate that to the CEO, that's going to be a very important discussion that you can have. And I think when you're trying to build, you have to make those efforts, not just to talk about these types of ideas, but to go out and get them. As a physician, you're very valued. You can do things that, that are very important. And Dr. Tsai, you were talking about, that, as a thoracic surgeon, I want to keep you busy being a surgeon, so that way you can continue to operate on these people and save these people's lives. And so, and that's your role as a pulmonologist. And I think that's something that I think is really important in the very beginning stages of trying to build a program.
So I want to, add to that. I think there's two perspectives that we really should consider. One is if you're looking at building a program as a pulmonologist, or if you're looking at building a program as a thoracic surgeon. I think the one thing every pulmonologist should do, again, this is not trying to sound, arrogant or boastful, which is very hard for a lot of thoracic surgeons to do. I think the one thing we have to recognize is that the programs that are probably losing money on robotic navigation bronchoscopy, independent of all the other margin eaters that Dr. Bhadra, described, was the fact that if they do not have a thoracic surgeon in that hospital system, those patients are going to go elsewhere. So all they've done only is diagnose lung cancers for that other hospital to say, hey, thanks Hospital X for sending these patients to me, because now I get those patients for surgery, medical oncology, radiation oncology. And oh, by the way, our CT scan is really good because we keep you in one center. So that is the true hemorrhage of every single program, is not to have a thoracic surgeon available to refer to that keeps that patient in this hospital system. I think that, once they had that, of course, when we usually talk to administrators, I always recommend that we do our homework first. And so what I usually do is I make sure that I meet with the pulmonologist first, so that way we all understand that when we meet with the administrators, it is not a single discipline that's making money for the hospital. It's the fact that Dr. Bhadra has generated 500 robotic navigation bronchoscopy systems. And oh, by the way, out of those, if 30% of those patients are positive for lung cancer, now my lung cancer surgery, surgery volume increases. Whereas before, if they went to a CT guided biopsy, interventional radiology biopsy, that patient may not necessarily stay in your hospital system, because that is a pathology that gets generated as a report, and the pulmonologist, the family practitioner who is not part of the hospital system may say, oh, well, listen, hey, we're going to refer, to some, other hospitals down the street, because of the fact that they don't recognize that, that hospital, may be, sophisticated in all their lung cancer, treatments. So when I go and talk to administrators, I always try to make sure that there's a meeting before with a key player, and usually those key players are the pulmonologists, and believe it or not, the interventional radiologist. The reason why is because if you think about it, interventional radiology procedures, CT guided biopsies, these are low payers for the hospital. Our hospital makes $1,700 per CT guided biopsy. Dr. Bhadra talked about the financial reimbursements for a robotic nav bronch system. It's 6 times higher. The biggest problem with interventional radiologists is if they get their dreaded, 15 to 30% pneumothorax rate, that patient goes into hospital and they have to stay there, which is a huge margin loss for these patients, for the hospital, because that $1,700, that's going to be eaten away by that one night of stay, and that patient may stay actually 2 nights depending upon the size of the pneumothorax. So the interventional radiologists, believe it or not, they hate doing CT guided biopsies. They would rather do things that are much more profitable to their hospital systems, i.e. access procedures and so on and so forth. So if that interventional radiologist is, again, we all know IR guys, they have contracts of exclusivity with the hospital. So that means that no matter how many cases they do, as long as they meet their quota, they're going to be paid that number X. So these interventional radiologists are willing to say, hey, listen, I'd rather just have, Tsai and, all his pulmonologists do these CT guided biopsies, these CT guided biopsies for me, because of the fact that I'd rather spend my time doing cases that make more money. And of course, when administrators hear that there's a trifecta of someone that's going to feed the cases, someone who could take care of the cases, someone who can get away from complication of the cases, and also make more money if they refer to Bhadras and Kovacs, and also make more money if they do other, spend their time doing other things. That is your trifecta of a perfect sort of argument or, justification for the investment in this capital. So again, that's what I, kind of see. Just again, as Dr. Kovacs says, know your key players, make your friends. Do not go about this as this is my patient where I'm going to own, because now we got a tug of war, right? It cannot be that way. As long as that patient stays within the hospital system, again, as Dr. Bhadra described and Dr. Kovacs described, that rising tide does truly raise all ships, but that patient has to stay in the hospital system, and everyone in that room needs to be committed to that one fact.
Amazing, amazing, great insights. Well, with that, I know we are way over time, and I appreciate everyone staying on for this, but I think we'll let everyone go. Thank you for attending, and thank you to our presenters this evening.
Thank you so much, everyone. Have a good night.
Thank you, everybody.
Thank you, Allison. Thank you, Dr. Tsai and Kovacs.
Yeah, thanks, everybody. Appreciate it.
Good night.
Take care.